Hi, as most of you already know, I'm Tiffany Anzano, and I'm going to talk to you about improving patient safety after anesthesia. Patients are vulnerable after ambulatory surgery. They rely on us and trust us nurses and their surgical team in making sure that they are safe during the most vulnerable moments after anesthesia and surgery. Assessments need to be made and criteria must be met in order to provide a safe patient discharge. Following proper criteria such as the Aldrete scoring system, as well as allowing adequate recovery time for all patients, improves their safety and well-being while promoting positive patient outcomes. Patient safety after ambulatory surgery is crucial in promoting positive patient outcomes. The Aldrete scoring system is a valuable tool in assessing patients for home discharge. The Aldrete scoring system assesses the patient's abilities relating to motor activity, respiration and breathing, circulation, consciousness, and oxygen saturation. The highest score a patient could receive is higher than 10 or more. The lowest score that a patient would receive is less than 10. And if a patient does receive a score less than 10, such as a 0, they would be sent to another medical facility, such as a hospital. Criteria using the scoring system, as well as allowing adequate recovery time in order to assess the patient's home readiness in terms of safety, can decrease the risk of possible complications. And this is a picture of the Aldrete scoring system, which would be incorporated into the patient's PACU chart. And this would be a permanent paper that I would incorporate into their PACU record. And as you can tell, it is 5 distinct categories. 1 would be motor activity, 2 would be breathing, blood pressure that's compared to the baseline blood pressure before they actually have the surgery, their consciousness, and oxygen saturation. Each category has different ratings, a 0, a 1, or a 2. An example of a 2 in the motor activity would be spontaneous movement when addressed. An example of 2 in the breathing and respiration category would be coughs on command, or they're crying, they're able to get air in and out. A 2 would be representative in the blood pressure category of changes of less than 20 millimeters of mercury compared to their baseline. A 2 in the consciousness category would be that they're awake, they're easy to arouse. A 2 in the oxygen saturation category would be that they have an oxygen sat of 100 to 98%. Increasing the patient's length of stay in the PACU before discharge can increase positive patient outcomes by providing adequate amounts of time for the patient to recover, and also using the Aldrete scoring system as used for criteria before allowing the patient to go home for a safer discharge. Currently, we do not have a policy set in place that says, the patient has to meet this criteria before being discharged. Policies need to be made and followed by each member of the post-anesthesia healthcare team according to proper guidelines and patient criteria using the Aldrete scoring system. Patient safety after anesthesia is extremely important. Making sure that each patient has a sufficient amount of recovery time is essential in maintaining patient safety after discharge. Applying criteria for all patients to meet prior to discharge can reduce complications and increase overall patient satisfaction and safety outcomes. In ambulatory surgical patients, how does discharging a surgical patient prematurely before meeting the Aldrete scoring system criteria compared with patients being discharged after meeting the Aldrete scoring system criteria affect the safety and outcomes of patients? Anyone know? I did some research and found several randomized controlled trials, and it was interesting to know what effects anesthesia had on patients that underwent ambulatory surgical procedures in reference to or in regards to their cognitive and ambulatory ability. In this randomized controlled trial, researchers studied the effects of 2 different types of anesthetic drugs, such as sevoflurane and propofol. The groups were divided into two different groups. One did receive the sevoflurane, one received the propofol. And then psychomotor testing was done in the PACU at various times throughout the recovery phase. And the psychomotor testing was just done to assess the patient's cognitive and ambulatory abilities. Patients in the sevoflurane group recovered faster than those patients that was in the propofol group, but both groups still needed a sufficient amount of time in PACU to recover safely from the effects of anesthesia. So this study was proven that no matter which anesthetic that patients receive, adequate time and assessments must be given to ensure that patients are discharged home safely. This randomized controlled trial assessed the cognitive and behavioral functions in patients that received sevoflurane, propofol, or a combination of these anesthetics. So one group just had the sevoflurane by itself, one group had the propofol by itself, and the other group just had a combination of the sevoflurane and the propofol. The groups were allowed to recover in a supervised PACU environment. An analysis of cognitive and behavioral functions were assessed, and they used the Aldrete scoring system and the behavioral pattern scoring system at various times. Significant differences, though, were seen in all groups with regards to that Aldrete scoring system, 2 hours postoperatively. But no differences were noted in the behavioral pattern scores with patients that were assessed 2 hours postoperatively. Even though recovery was shown to be faster in the group that received the propofol, followed by the group that had the combination of drugs, it still was necessary that adequate amounts of time in the PACU environment was needed for patients to recover. This study is indicative that mental status in regards to cognitive ability should be assessed using this Aldrete scoring system, and stability should be gained before discharging patients from the facility. This randomized controlled trial was very interesting to me because, as you know, we have a lot of obese patients that visit our facility. They have surgery anywhere from having breast reductions, abdominoplasties, liposuction, etc. And this randomized controlled trial was done to assess the effects of the desoflurane and the sevoflurane in regards to recovery time in obese patients having laparoscopic bariatric surgery. Patients were grouped into two groups, and of course each group received one of these anesthetic agents. It was noted that the desoflurane group recovered faster than the group that did receive the sevoflurane, but both groups needed to have adequate recovery time to regain normal cognitive function. Groups were assessed in the immediate and intermediate postoperative period using the Aldrete scoring system again and with a digit substitution test. Studies showed that there is a link, which I found very interesting, between obese people and prolonged recovery time. This, however, is due to the propensity that the anesthetic agents accumulate and linger in these adipose tissues. The study also showed that obese patients regain slower cognitive function than non-obese patients, regardless of the anesthetic choice. This proves that a sufficient amount of recovery time needs to be given to patients, and that is, it is imperative that proper time and assessment using a scoring system be given to promote positive patient outcomes. This is the last randomized controlled trial that was researched, and it was done to assess the cognitive ability of patients to recall a list of objects given to them verbally. And they were told in the postoperative period they'd be assessed at a certain time later. Patients were assigned into two groups. One group received propofol, and they were labeled early group. And then the other group was the control group, also known as the late group, and they received no hypnotic drugs at all. Patients in the early group was given a list of 5 objects in the immediate postoperative period and was told that they'd be reassessed on their recall ability again in 30 minutes. The patients in the late group was given a list of 5 objects verbally 30 minutes after being discharged. The test concluded that the majority of patients in the early group had no recollection of ever being given any information compared to that of the late group. The late group did show that they could actually recall those objects. This trial has demonstrated that patients do have impaired cognitive abilities after anesthesia is given and should be given adequate amounts of time to recover in the PACU environment until cognitive stability and mental alertness has been regained. This proves that patients should be able to recover in a highly supervised environment until they are stable and alert and are able to recall information such as discharge instructions that's given to them before they are discharged home. Educating all team members, including the physician and the nurses, on the importance of the new policy is essential. Discussing the risks such as not having a policy for discharging patients versus having a policy for discharging patients in order to promote safety in the PACU environment is vital. An Alderet scoring system will be discussed in detail to include those 5 categories with the scoring in each category. To note that no patient will be discharged with a score of less than 10. Alderet scoring also should be done every 15 minutes to assess the patient's recovery status as far as regarding the cognitive and ambulatory abilities. After educating all team members, a revised flow sheet should be made with the Alderet scoring system included. This can ensure quick access to the scoring system and to see the patient's progression through recovery. Weekly and bi-weekly meetings will be held to assess team members' ideas on the new policy and to report patient outcomes, satisfaction with overall surgical experience, as well as the PACU environment. Evaluations will be done, and they're done to ensure that the changes bring forth benefits not only to the patients, but also to the nurses in the PACU as well. Patient evaluations will be done by phone calls. Usually a 24-hour follow-up phone call will be given to assess their satisfaction with their PACU experience. Also, questionnaires will be given 7 days post-operatively, which is usually their first post-op appointment. And that would require having a rating system of the entire surgical environment. This would include a section of the post-anesthesia care unit and the readiness the patient felt that they had at the time of discharge. Personnel evaluations can be done in meetings bi-weekly or weekly to discuss employee satisfaction with the new policy and ideas for any changes if needed. All patient questionnaires that I talked about in the 24-hour follow-up phone calls, those answers or the information that we got back from the patients will also be discussed at those meetings so that we can, kind of go over that and find out, if things are working or if change needs to be made. Use of the Alderet scoring system by all nurses in the PACU can increase positive patient outcomes as a way to assess the patient's cognitive and ambulatory functions in terms of discharging those patients home safely. That scoring system can reduce complications and improve safety by nurses utilizing it in the PACU because it'll be right there in that flow sheet, and the nurses will have it at their fingertips, which will allow quick access to the patient status while in the PACU environment. The research provides evidence that all ambulatory surgical patients need adequate amounts of recovery time, no matter what anesthesia is used during surgery. Early discharge of patients from the post-anesthesia care unit after ambulatory surgery places the patient at increased risk for health and safety issues such as falls, bleeding, etc., due to decreased level of consciousness. A valuable tool using the Alderet scoring system needs to be in place to assess the patient's cognitive and ambulatory functions and is essential in promoting a safe discharge and increasing positive patient outcomes. That concludes my presentation. Are there any questions? Thank you.